Very good morning to all of you. I think we are moving into the Symposium number 12 of our Congress, and it is on a subject very close to my heart, and that is about urolithiasis and best care in 2022. As you know, it makes the sort of largest workload for a urologist and also for general surgeons. Until there are many, many more urologists in the country, it will be shared by the general surgeons as well, the burden of stones. Without further ado, I will introduce the first speaker in this symposium, Dr. Munipriya Willaraarachchi, and he will be talking about the basics of urolithiasis under the topic Understanding Urolithiasis. Podium is yours, Muni.
Thank you very much. Good morning, Chairperson, sir, and ladies and gentlemen. First symposium of urological wise, the urolithiasis, best of care 2022. So first, understanding urolithiasis, I am going to talk about, and this is my outline of. So urolithiasis, the word origin from Greek word, uron is urine and lithos is stone. The condition where urinary stones are formed or located anywhere in the urinary system, we call urolithiasis. Little bit about the history. So history goes back to early 19th century. The giant bladder stone found in natural mummy. So when history comes to the first urology, the stone surgery, that is recorded in Vedic times in India. That is Sushruta 1500 BCE time. So lifetime prevalence of stone formation is 1 to 15%. That is varying according to the age, gender, race, geographic location. The highest prevalence is in the southeast area, and the rising prevalence in global phenomenon. And you can see the stone belt, that is the southeast area. And stone formation is common in male and white compared to the Asian, Hispanic, and the African Americans. The peak age of stone formation, 40s to 60s, though it's less common in before age 20, nowadays rising incident in children and the adolescent. And geographically, Afro-Asian stone belt is the commonest area, then states, British, and this Canadian. And the climate-wise, the higher prevalence in hot and the arid or dry, the mountains, desert, and the tropical areas. Occupational-wise, it's important. The dehydration is most important part, and the heat exposure. And obesity, when the BMI is high, the excretion of urinary oxalate, uric acid, sodium, and phosphorus is increased. Because of that, supersaturation and uric acid formation, stone formation is increased. And further, the promoters of stone formation is increased with the obesity, and pH also contribute to this part. And systemic disorders like diabetes and the metabolic syndromes is important, and cardiovascular disease and the chronic kidney disease also contributing to stone formation. So water is the beneficial. The high fluid intake will prevent the stone formation. So pathogenesis, the basically lithogenic urine, stasis, infection, and the foreign bodies will cause the stone formation. When come to the lithogenic urine, hypercalciuria, hypoxaluria, hypouricosuria, and hypocitraturia, and urinary pH less than 5.5 is important. Stasis-wise, PUJ obstruction, ureterocele, chronic obstruction with bladder outflow obstruction, and the low pressure system in urinary diversion pouch. So few examples. So you can see here the PUJ obstruction causing large stone formation. This is the one cause for stasis. Then bilateral staghorn and the unilateral staghorns and the bladder outflow obstruction due to bladder stone you can see. And the lower two pictures shows the low pressure system, intestinal urinary diversion pouch causing stone formation. This is again the abnormal anatomy of the system. So duplex system causing stasis, and you can see the left side stone formation within the duplex system. So this is the horseshoe kidney, which caused the stasis of urine within the system, causing the stone formation. Then foreign body, the right side picture shows the whitish thing is the piece of catheter encrustation around the foreign body causing stone formation. So, however, in pathogenesis, urine supersaturation is the most important thing when the stone formation. Supersaturation is not alone is not sufficient to crystallization of the urine, but because of that, inhibitors of crystallization or nucleation, growth aggregation done by nephrocalcine, uropontine, TAM-Hall protein, like that stone preventive proteins are there. So other than that, urinary calcium and the oxalate contribute equal to saturation of the calcium oxalate. And the origin of common calcium stones based on subepithelial plaque composed of the calcium apatite serve the anchor of the calcium oxalate stone. And the metric stones, non-crystalline component like the mucoproteins, proteins, carbohydrate, and other urinary inhibitors. So this picture shows the state of saturation in urine. So usually the solubility product and the formation of product different three major status of the saturation in urine, that is unsaturated, metastable, and the unstable. We can divide it into three levels. In unsaturated level, the crystals will not form and existing stone may dissolve. When come to the concentration of products, that is metastable state, so some stones start to form, but formation of product, that is the point at which it can no longer be held solution, so crystal forms, that is the nucleation will occur, and the inhibitors not generally effective in that stage, that is unstable urine. Little bit about the composition of the stones. The majority of the stones are calcium oxalate and the uric acid and infectious stone. Earlier staghorn calculi, most of us think about the infections caused the staghorn calculi, but nowadays evidence shows the calcium oxalate and uric acid is the composition even in the staghorn calculi. These are few studies done in Sri Lanka. The one is Dr. Anuruddha Abegunasekara done chemical composition of kidney stones obtained from Sri Lankan patients. Majority of renal stones, 86% is calcium oxalate. And further in that study shows only 5% of staghorn calculi is having the struvite or the infectious stone. The other study is done by Dr. Rajendran, that is a cohort taken from the Jaffna area, northern area of the country. So again, he has concluded calcium oxalate is the commonest type, and followed by uric acid 13%, and the carbonate apatite is 7%. So how patients present depend on the site of the stone location and the impaction and the infection of the status, and the renal function of contralateral kidney also important to when the patient present. The classically obstructed ureteric stone is present with the ureteric colic. The triad of symptoms is low into groin pain, nausea and vomiting, and the hematuria. And however, we have to exclude the broad range of differential diagnosis before diagnosis the ureteric colic. And nowadays, because of the newer techniques, so we will found the asymptomatic cohorts as well. So when we come to the stone workup, the basic investigation, the urine analysis is important. In urinary analysis, red blood cell, WBC level, and the urine crystal is important, and the urinary pH is important. Urine culture is the important thing. Then renal profile, serum creatinine, blood urea, serum electrolyte, pH and the bicarbonate, calcium, phosphate and the uric acid level. Radiologically, gold standard is non-contrast CT-KUB, and in poor resource setting in Sri Lanka peripheral areas, we can do the ultrasound KUB with the X-ray KUB to replace the NCCT KUB. And 24-hour urinary analysis is recommended only for high-risk stone recurrence patients, but stone analysis with infrared spectroscopy is the gold standard technique to analyze. It is very important to manage the patient with the stone disease. And this is the high-risk group which we have to do the 24-hour urinary analysis. Thank you.
Our next speaker is Dr. Nishantha Liyanapathirana, consultant urological surgeon from the teaching hospital Anuradhapura. He'll be talking to us about the high-tech revolution that has taken stone surgery from open to very, very advanced stage. So, Nishantha, please address.
Yeah, thank you very much. Very good morning to all of you, and Chairperson Sir, dear colleagues, and thank you for inviting me for today's talk. So I'm going to be briefing about the recent advances in endourology for stone disease. So this is the outline of my talk. So we're going to be talking about the new tech in obstructed ureteric stone management, renal stone management, and bladder stone management. So urologists are the pioneers of minimal access surgery. So we have shifted to minimal access surgery a long time ago, and we left the open era many decades ago, and almost all our surgeries are done endourologically and minimal access fashion. So based on that, we have the advantage of evolving ourselves to develop sharp tools. So we got high-tech scopes, and we got better lasers. So when it comes to the ureteric stones, we use semi-rigid scopes for the management, and also we use flexible scopes. So semi-rigid scopes, our semi-rigid scopes are getting thinner and thinner these days, and the optics are getting better and better. And same thing goes with the flexible scopes. They're getting thinner, and the image is getting superior day by day. And the recent iteration, which is added to the armamentarium, is the single-use disposable ureterovenoscope, which is lightweight and also which is digital, plus very cost-effective. So just to give you an idea about how thin the modern-day ureteroscopes, you can see a double-J stent in the bottom picture, which is 6 French. And you can see the ultra-thin ureteroscope, the size is around 4.5 French. So you can appreciate the size and the amount of miniaturization which has taken place. So as we discussed, the digital revolution of the flexible ureteroscope has made wonders. And as you can see in the picture, the newer generation end-on-chip digital scopes got superior image quality, and the difference is day and night. So we talked about the scopes, but what about the energy source? So for the decades, we used the standard low-power holmium laser. Then recently, with the evolution of the high-power holmium laser, stones were treated much efficiently, and also with a very, very quick time, in a timely manner. However, the recent iteration, the newest iteration is the thulium laser, which is the new kid on the block, which is getting, day by day, getting quite popular among the stone surgeons because of its high energy deliver with a very, very thin fiber. And also it has got very high energy frequency, which is around 2,000 to 3,000 hertz, and also much less retropulsion. All in all, it is getting the laser of choice for the next generation, and we're going to see more development in the recent future. So many a time we've been asked the question that can we treat every stone, any part of the urinary tract? Well, it is quite possible with the modern technology, and this is one of the good example of a renal stone in a malrotated kidney. It is in one of the calyx. And in this case, he has got a low ureteric stone at the same time. So what you can see is the lasering of the low ureteric. This type of low ureteric tiny stone will never pass however much you treat, because you can see they are spiked and quite tightly adhered. And we're going inside with the flexible ureteroscope. We visit all the calyces and then enter into the targeted calyx and then use the high power laser to fragment the stone into tiny dust particles within no time. So we come to the second part of my talk, which is the treatment of renal stones. So we all know that the renal stone can be tackled by many ways, but the two common ways is the retrograde approach, which is the flexible ureterorhenoscope, which you have just seen on the images. And we all agree that the large stones has to be dealt with PCNL, which is the standard of care. So when you talk about the PCNL tech, it has advanced in two key aspects. One is the miniaturization of the PCNL scopes, and the second one is the liver energy sources. So at the inception, we use standard 30 French nephroscope, which are called thunderscopes nowadays, with a lot of bleeding and a lot of post-op pain. Nowadays, we use, more and more people use the mini PCNL, which use the tract size of 20 French, which is very effective in combination with the laser. And many centers have shifted to ultra mini PCNL, a further miniaturized version. It has gone really crazy and has gone down to micro PCNL now, which 4.85 French access sheath, which means literally a needle aspiration of a renal stone, with, of course, with many limitations, but selectively, it's going to give way better results. So what are the energy sources we have? Good old new generation energy source combined with the old generation. These are pneumatic lithotripsy, which has a distinct role in this part of the world, because as in the previous speaker's presentation, you saw that the many stones are calcium oxalate monohydrate. So hard stones are better dealt with the pneumatics. And at the same time, we have ultrasonic lithotripsy, which can aspirate many of the pelvic stones very effectively. And the real game changer is the high power holmium laser, which has recently entered into the scenario. So these lasers can, in no time, they can just fragment the stone into tiny, tiny dust particles, and you don't have to spend time to go and fetch the small particles. I'm quite lucky to have all these three technology in my hospital at Anuradhapura, and all these images are taken from my cases. So this is another example of how well you can treat large renal stones. This is another patient presented to us with large bilateral renal stones, staghorns, which can be effectively dealt with a single tract, especially when you have the technology available at your hand. So the biggest benefit of the miniaturization of the scopes and the technology are the pediatric population with stones. So they are the biggest benefiters. This is a 3-year-old baby presented to us with a large impacted staghorn calculus in the left kidney at Anuradhapura. And then this patient had a mini PCNL, So we've entered into the calcial system using a very tiny 15 French sheath. And then using a 12 French nephroscope, we could easily reach into the renal calyx and use of high power laser effectively fragmented entire stone, including the upper ureteric segments. So you can see the complete clearance is achieved with a very minimal incision, and minimal incision means less pain, which means happy customers. So both of them are ready to be discharged in post-op day 2, smiling and about to go home. So last but not least, the last bit is the treatment of the bladder stone, how it has changed. So as you all know that many of the large renal bladder stones we used to do vesical lithotomy because it's not very effective to do endoscopic management. But recently this has changed with the shifting towards the percutaneous vesical lithotomy, which we use a access sheath suprapubically. This is another child presented to us at Anuradhapura. 2-year-old child with a large 3 centimeter bladder stone. You can appreciate the size of the stone, and we go ahead with this case. We went ahead with the suprapubic track into the bladder, and with the use of high power holmium laser, we could effectively treat the stone into quite a tiny fragments and washed it out. And the biggest advantage of this particular mode of surgery with the technological advancement is that you can remove the catheter in 3 days' time, and you don't hardly need to put any stitches, and child can be pain-free and can be discharged in post-op day 3, 4 without major concerns. So thank you very much for your kind listening.
Thank you, Nishantha, for that very impressive work you are doing at your place. Our next speaker is Dr. Kalana Parana Palliya Guruge. He's a consultant urological surgeon at the teaching hospital Kalutara. And he'll be talking to you on miniaturization of percutaneous nephrolithotomy. Kalana, over to you.
PCNL was introduced back in 1976 by Frenstrom and Johansson. It's now a well-established technique to extract upper tract renal stones. PCNL has the highest stone-free rate in a single session when compared to its other minimally invasive rivals, namely shockwave lithotripsy and RIRS, also known as flexible URS. Each of these 2 massive renal stones were treated with PCNL with a single setting. Both the European and American urological authorities have endorsed PCNL as the first choice in treating large renal stones more than 20 millimeters, irrespective of the location. Understanding the renal anatomy is the key for a successful PCNL. Kidneys are paired, highly vascular retroperitoneal organs. They have a peculiar 30-degree angulated 3D arrangement. And kidneys are closely related to the pleura and the colon. Accessing the kidney through an avascular plane makes way to a smooth PCNL. The standard nephroscope is 24 French, and it can be used with or without its own nephroscope sheath, which is of 26 French in size. The access sheath or tract sizes can be vary from 22 French to 30 French. As you can see here, the mini PCNL nephroscope surface area is 1/5 of the conventional PCNL nephroscope used with the sheath. If the PCNL tract dilatation is less, there will be comparatively lesser chances of renal parenchymal insult. Miniaturization isn't just the reduction of the tract size. There's many PCNL steps are revolutionized. Serial telescopic or balloon dilatation of access tract is in standard PCNL is replaced by single step dilatation. In microperc, the access needle is used without any dilatation process. The access sheets are also different. Single-use Teflon Amplatz access sheets in standard PCNL is replaced by metal multi-use access sheets in mini PCNL. Stone shattering energy sources are also changes by miniaturization. In standard PCNL, pneumatic, ultrasonic, electrokinetic or combined lithotripter and lasers can be utilized. But in miniaturization, only feasible energy source is laser. Holmium and thulium lasers, both low and high power, is available for high efficacy stone disintegration. In standard PCNL, stone fragments are larger and they are retrieved by graspers. In supine PCNL, the fragments are evacuated by gravity. In mini PCNL, fragments are being evacuated by whirlpool effect or vacuum cleaner effect. Super mini and ultra mini PCNL uses concurrent suction. During exit strategy, standard PCNL may use a nephrostomy, but in miniaturization of PCNL, they mostly be tubeless. During the past decade, there has been a paradigm shift in PCNL from conventional to miniaturization, and it has become very popular now. Mini PCNL armamentarium using single step metal dilators and reusable access sheath, and the tract sizes ranging from 14 French to 20 French. And this super mini PCNL uses a controlled suction mechanism integrated to access sheath, making evacuation of stone particles and stone dust effectively. The ultra mini PCNL uses a specifically designed Amplatz sheath with an eccentric irrigation channel, generating an vertex effect in retrieving stone dust. Micro PCNL is almost the size of a 16-gauge needle. It has the all-seeing needle with integration of irrigation channel, telescope, and working channel with laser. And it also comes with a flexible nephroscope. Miniaturized PCNL has shown less drop in hemoglobin, less requirement of analgesics, and obviously lesser hospital stay, keeping the same efficacy of stone-free rate. The guidelines will be revised as miniaturization of PCNL gets more stabilized. Complete staghorns will be just museum specimens, and in years to come, all the large kidney stones will be turned into sand. No more large cuts along the side of the belly to retrieve kidney stones as the urology services flourish in the island. Thank you.
Thank you, Kalana. The next speaker will be talking to us whether there is still a role for open surgery. Dr. Musthafa Thaha is a consultant urological surgeon at the General Hospital in Nuwara Thaha, it's yours now.
Good morning, Chairperson, sir. Ladies and gentlemen, I am honored and privileged to deliver this talk in front of my beloved teachers. After all of these excellent presentation of high technology and miniaturization, it is my duty to summarize things with the answer to this question: is open stone surgery is obsolete? This is the outline we are going to talk about today: the history of stone surgery, and whether it is feasible to do stone surgery in complex and complicated stones, such as calyceal diverticular stones, complex staghorns, when there is coexisting PUG obstruction, stones in transplanted kidney, stones in horseshoe kidney, and patient with spinal deformities. An ureteric stone, when there's a presence of ureterocele and large ureteric stones. And how are you going to deal with large bladder stones and stones in neobladders and urinary diversion? What are the recommendations from guidelines? Are they recommend open surgery or minimally invasive surgery for these kind of stones? And whether these are feasible locally in Sri Lanka? For a successful surgeon and a satisfied patient, we need a surgery which improves clinical outcome with minimal renal damage, reducing operating time, complete clearance of the stone with no need of second operation, and should be cost effective definitely, and it should have an acceptable cosmetic outcome. So one by one, we do not need this kind of scars anymore. And absolutely, patient safety is always the first. The history, so it started with open surgery in 1879 with parallithotomy and then nephrolithotomy, and further it has improved and ever evolving and continuously improving with invention of high power lasers, miniaturization of scopes. How are you going to deal with complex and complicated staghorns? Earlier, it is meant for open surgery, but we can do with multi-tract PCNL with better cosmetic outcome. This paper says complete clearance and early return to work with shorter hospital stay, which the patient needs absolutely. Again, this is another evidence for good stone-free rate of 91%. Remember, these papers are coming when the techniques were in their child age. Now with the influence of high-power lasers, holmium lasers, and thulium fiber lasers, it should be definitely more than this number. Calyceal diverticulum, it's an outpouching of urothelium covered by transitional epithelium, which is non-secretory. It can present in every pole, mostly in the upper pole. Earlier, this has been thought we could not reach these stones endoscopically from ureteroscopy, neither by percutaneous nephrolithotomy. But the story is different. We can do percutaneous nephrolithotomy if the calyceal diverticular stones are in the posterior part of the kidney, and we can do flexible ureteroscopy if it is in the upper pole and the interpolar region, and we can do laparoscopic surgery also when the diverticulum is anterior and the overlying perineal parenchyma is very thin to hold the PCNL sheath. And we can do neck incision for the future proper drainage. The presence of coexisting PUG obstruction is not enough to clear the stones. We can do laparoscopic parallithotomy and paraplasty at the same setting. If it is a failed parallithotomy in the past, we can do percutaneous nephrolithotomy and laser incision of the scar tissue. So we all know operating in a previously open procedure it's going to be a nightmare. So minimally invasive surgery is the best option when there is a previous palliatomy. Patient with spinal deformity. It's a difficult task for the surgeon, which the patient has issues, anesthetic issues, positioning, and access to the renal system. It can be achieved, but we can do flexible ureteroscopy for smaller stones, and we should consider supine position, ultrasound-guided puncture because of the positioning difficulty in these kind of patients. What about the stones in transplanted kidneys? They might lie in the iliac fossa, which are superior to the skin surface, which can be accessed with ultrasound-guided puncture and can be cleared with minimally access or minimally invasive surgery. Horseshoe kidneys, they are prone to get stones because most of them, almost 100%, will have some kind of metabolic abnormalities. 1/3 will have obstructed flow, and 1/4 will have stone formation. PCNL we can do with upper pole puncture, relatively safe because it is away from the pleura, but there is a risk of colonic puncture. Flexible ureteroscopy, safe, but there is a difficulty of kinking of ureter and anterior insertion of the ureter to the horseshoe kidney. Only problem we might need a lengthier scope because the kidney is more inferior and anterior when we access from the in the prone position from posterior. Pelvic kidneys, they are more prone to get stones because they are malrotated and high insertion of ureter. This will cause obstruction of the flow. Again, minimal invasive surgery is possible and feasible, safe. In supine position, we can do transperitoneal PCNL. With laparoscopy, we can do the stone clearance. So laparoscopic assisted PCNL is safe. It is minimally invasive for patients with ectopic kidneys presenting with large stones, and it's a safe, feasible technique with good results. Large ureteric stones. The previous or in the past, the teaching was to do a ureterolithotomy. With the miniaturization of ureteroscope, both rigid and flexible, with a high power laser, we can access them and we can do good stone-free rate. In the presence of ureterocele, which is the cause for stone formation, alone clearing the stone won't be enough. We can do incision of the ureterocele, either cauterization or with a holmium laser, and clear the stone and drainage the system. Large bladder stone. The previous speakers told about PCVL, percutaneous vesiculithotomy. Earlier, the patient should carry a drain and a catheter after open vesiculithotomy. Now the story is different. We can do percutaneously with dusting of the stone and total clearance. In transvesical laparoendoscopic single-site surgery, with the help of laparoscopy also, we can do bladder stone clearance. What about the urinary diversion? We can do endoscopically or percutaneously because they have, in this paper, they have selected endoscopically because they do not want to damage or interfere the natural or the preferred drainage system. And this is another example of percutaneous approach of stones in the neobladder, which is an acceptable, safe, and effective method. Let me have a look of guidelines. What about EAU? For complex and complicated stones, they all recommend minimally invasive surgery. Calicial diverticulum, horseshoe kidneys, pelvic kidneys, continent reservoir, or obstruction in the PUJ, a transplanted kidney, they all recommend minimally invasive surgery. You can see there are rare cases in which shockwave lithotripsy, retrograde or antegrade ureteroscopy and PCNL fail, are unlikely to be successful, and then we can recommend open procedure. AUA guidelines, and again, same thing. If the total renal burden is more than 2 centimeter, PCNL is the first choice and is standard of care. NICE, again, it is not different in the NICE guidelines. Even for pediatric stones, renal stone more than 20 millimeter, we have to consider minimally invasive surgery. Ureteroscope for ureteric stones. And in our part of the world, it's not different. UAE guideline and Japanese Urological Association, they also recommend minimally invasive surgery even in difficult anatomy. This is for the renal stone. That is ECIR is endoscopic combined intrarenal surgery. This is the ureteric stone. Again, minimally invasive surgery is preferred. About the bladder stones guidelines, you can see the open surgery at the bottom of the flow chart. They start with minimal invasive surgery. Even EAU, they start with minimally invasive surgery. An open procedure is preferred when all these kind of minimally invasive surgeries is not feasible, which is very unlikely. Because of this recommendation and the teaching, you can see the downtrend of open procedures. This is the world trend. And you can see that again, the ureteroscopy and shockwave lithotripsy is increasing and the open technique demising. Even the papers coming in the midline, you can see the papers for open procedures is moving away. When we consider health economics, the western part of the world, it is comparable, minimally invasive surgery is comparable to open procedures, but when we consider our part of the world, it is better when we compare with open procedure. And when we combine the early discharge and early return to work, definitely it's going to be more cost effective. So the worldwide, 1 to 5% of open surgeries. In the developed world, only 1%. And developing world, there is a sudden decrease in the percentage from 26% to 3%. And it is on further decrease. But it is feasible in Sri Lanka. It is part of the Asia-African stone belt. In 2014, the situation was different. We had only 24 urologists covering 20 million. But the story is different now. There are 41 urologists covering the whole country, and any patient can access any urologist within 2-hour drive. In conclusion, minimally invasive procedures for urolithiasis are safe, are effective with good stone-free rate, it's feasible with regional anesthesia, and because of that, we can do as day case procedures. They are recommended by guidelines, even in complex stones and complicated anatomy. It ensures patient for early return to work, and definitely it is cost-effective and highly cosmetic. And it is continuously evolving and progressing. Now I have to answer this question. I think the answer is very obvious from the other talks also. And it has been set and well registered many years back. I will not cut even for the stone, but I will leave such procedures to the practitioners of that craft. That means who know how to do it by minimally invasive surgeries. Thank you for your listening. That's the take-home message.
Thank you, Dr. Thaha. Traditionally, I think because this is a symposium, before winding it up, I'll open the podium to the podium to ask questions. If there are any burning questions, we have to limit it to maybe 1 or 2 questions. If there are any questions, all the speakers are ready to answer. I thought Professor Alvihari might ask a question because we don't want to be the devil's advocate by promoting open surgery. But I think till we have many more urologists in the country, open surgery might play a role until it becomes a problem of litigation. So when the guidelines are very strong, you might do open surgery, and if it gets complicated, you will end up in courts. So that nobody has reached that level, that stage yet, but I think we are coming to that. So just a cautionary word to the general surgeons, because at the moment it's okay, but be careful before you take a decision. I'm not threatening or anything. Just be careful before you cut open a chap for a stone. Just find out whether he's a lawyer or a judge or somebody. Okay, then. And I must thank all the speakers who did their job very well and keeping up with the time. And let us show our appreciation in the usual manner. This concludes the session.